Hi, everybody. Good evening. I'm Tom Furkovic. Thank you for doing this. We thought it would be a good idea that considering that we just had an election, and what made it unusual is all three branches of government are now controlled by one party, which is different than what we've had. And so we thought, as you do your business plans and as we take a look at 2025 and 2026, we should have some thoughts about whether or not you should be revising or whether or not you should be considering some options that may not be right in front of you today. So I want to introduce the people that are going to help us out. First guest that has been gracious enough to do it for us is Neil Johnson. Neil is the managing partner at Lawrence Evans, which is an investment bank out of Columbus, Ohio, and he's got a couple other branches. But what I love about Neil is he's very entrepreneurial. He's not just the investment, he is on our healthcare side, and he can tell you about himself as he goes through it. Dr. Harry Leader will be joining us. He's the former chief medical officer of Walgreens. He is also has a company that provides fractional CMO work for other organizations, and he's board member of a number of for-profit organizations. Then two of our Medvallistas, Ken Siegel, who's the CEO of Value Capture, as you guys all know, and Wade Erickson, who's CEO of Medical Network of Alaska. So the format's going to be, I'm going to moderate. I'm going to ask each of these panelists to talk for about 5 minutes, give us 3 or 4 items that they think we should be looking out for based on their best crystal ball. The panelists they're going to actually talk to each other within the time frame for each of the topics. And then about 50 minutes in, we're going to open it up for questions. But if you have questions in between, feel free to start writing them down and sending us notes. This is being recorded. So we're going to put all of you on mute for the beginning, but at the 50-minute mark, when we go to questions, we're going to turn off the recording. We're going to be able to say whatever we want to say and feel a little more free to have if there's some controversial things you want to talk about. So tonight we're going to start it off because the biggest player in most of the in American healthcare is actually the health systems. And I'm going to ask Ken to kind of share with us what he's learned, what he's hearing from his colleagues, and what he's seeing. Ken, thank you for doing this.
Yeah, of course, Tom, and it's great to be with everybody. And let me just say, we're in a sector that's well plugged in a government affairs way, and a lot of people on the phone and the audience have great information as well. I think I got tapped to do this because I have a background in policy before I got into the real work. But when I think about how long ago I was in DC, right in the thick of this stuff, it was now 3 decades ago. So consider that, how long ago that was. But I was in a very insidery conference in DC with people who are very tight and close to the Hill and the incoming administration behind closed doors. And that was 10 days ago. And 10 days ago at this point may as well be 6 months ago, right? Because, the moment we're at sort of feels a little bit like if you like sports radio, listening to sports radio on a Wednesday, they've sort of turned from analysis of the last game and they know who we're playing and we're starting to know what players are going to be on the field, but then there's just a lot of talk, right? Until they actually line things up and go. So I'll try not to over talk in my sports radio thing here, but just a couple things in terms of organizing what could happen, especially from a hospital health system perspective, where so much of the money is. I think there are sort of 4 areas I'm going to point to, and I want to say the one that I think obviously we have to pay most attention to in the sector. And let me just say globally overall, healthcare, despite all the things we read every day in our press, is not at the top of the Trump administration's overall agenda. Certainly not for the president himself, right? He's got 2 or 3 other things that he's got higher in his thing. And that's probably most significant from a speed standpoint, right? It really is going to take a while for the White House's priorities to really zero in here. Apart maybe from the government efficiency stuff coming sort of into the bureaucracy side of it. But I do think, it'll be a matter of some time. So, I don't think instant revisions and strategy have to happen in general. You got to see what happens and, the continuing appointments and then how the policy stuff rolls out. That said, number one is definitely the sort of effort to save money and to get money out of healthcare that can be spent to pay for tax cuts and other things. And I'll say more about what's embedded in that. We all know what we're worrying about. The second most significant stream, I think, though, is the sort of animal spirits, the unlocking of deal making, of sort of taking some of the restrictions off. And Neil, you're going to talk about that. And I'll just mention some of the potential impacts for continuing trends in the on the health system side. The third, actually, most significant is the one that's taking a lot of the headlines, which is Make America Healthy, right? And some of the desire to shake things up on that side. I think that definitely will play out over a longer period. And then there's a lesser bucket, which affects some of the health systems very acutely, which are issues related to healthcare that relate more to sort of the cultural battles. Um, and certainly making things difficult for some health systems, and that will continue. But the biggest bucket, I think, is money and saving money and the desire to do it. And here, health systems certainly worried about their budgets and impacts on potential revenue, and including my clients. And, let's just look at sort of the major buckets here. Obamacare. The insiders don't think that the administration will go after eligibility in a huge way. There might be work requirements and things like that, but they are quite sensitive to the possibilities of going after letting the subsidies for enrollment lapse later this year, and that of course sets up for millions of people to potentially not be able to afford the insurance, and that could have a big impact on statements. um Medicaid, another huge one, right, to pay attention to. It's quietly become extremely important. 75 million people on the program. The changes the Biden administration made in the last few years actually allowing significantly more money to flow, including in red states, to providers. It's now in the high single digits for revenue as average across the sector. Sorry, that's Obamacare. It's considerably more than that on the government side, and including, much higher rates, right? And some of the recent changes allow Medicaid payments in certain circumstances to be at commercial rates or above. And some of my clients and, in places that did not expand Medicaid are now quite dependent on Medicaid and quite excited about it. But Medicaid is in the crosshairs, and for many in Congress, it has been for a long time, including the growth of the program. So there is worry: would it move to block grants? Will there be caps, etc.? But very significant from a revenue standpoint. The other here is Medicare Advantage. There's broad support. If you look at the tendencies and the key appointees so far for moving more Americans into Medicare Advantage. And from a health system standpoint, that strengthens the payers, which have been continuing to consolidate, and their ability to hold costs down in their perspective and revenue down from a health system perspective. But it looks like Medicare Advantage will get a further push. Also, things like site neutrality. If health systems are not yet planning for getting paid the same, no matter where they do something, they better get on it in a fast way, because there looks like that's in the vein of something they're going to support. So I'm burning up too much of my 5 minutes, but this is the key one, and I think a lot of that stuff is what I would have my eye on. I don't necessarily think any of it's going to happen super fast, but that's where I would look at it. Neil's going to talk about deal making unchained from a health system standpoint. I just think it means further consolidation at the federal level, less looking at the mega mergers, and that will have our health system leaders looking up at the big systems. It'll mean the big get bigger, and those that are more vulnerable either will get snapped up or left further behind, sadly. But we can look at an acceleration of what the trends have been. Making America healthy. A couple things I'd look at here. Telehealth broadly favored, which is good. Looks like hospital at home, the extension of the waiver, that kind of stuff. That's good for innovation. We can accept innovation in this ways. CPT codes. You saw that Kennedy has convened a group to look at shifting more dollars to primary care and away from specialty care. AMA is undefeated at knocking that stuff back for a century. But something like that is probably, I will say, overdue from a national standpoint, but we'll see if they can get momentum behind it. Nothing will happen fast, certainly, in that area. On the culture fight, women's reproductive health care, very difficult situations occurring across lots of states. Children's hospitals and others that support gender affirming care, really in the crosshairs right now. Very difficult for those leaders and teams right now running those programs. One important piece I haven't mentioned, and I'll just wrap up here on back to the money, the big thing I'd be paying attention to. The secret revenue source for health systems recently, not so secret, but the 430B program of pharmaceuticals. A lot of my clients are very dependent now on this system to maintain profitability and stability. And there is worry about its vulnerability. Sometimes um, it is picking up real supporters in Congress, including on the Republican side. And so it's not by any means a foregone conclusion that the pharmacy subsidies would be at risk, but people are plenty nervous about it. Let me wrap up there. We can get into
Great.
discussions. As I
Perfect.
said, this is all Wednesday and the game is on Sunday, but we'll see what happens.
Great. And in just a couple of minutes, any Neil, Harry, or Wade, anything you want to add or ask Ken about from that? It's great,
Yeah,
great stuff.
uh, yeah, thank you so much, Ken. Very nicely done, a nice summary, very helpful. Um, when I hear your perspective of Obamacare or the Affordable Care Act and potentially the sunsetting of the subsidies, when I hear it and think about it, it's actually it feels even bigger than the way you characterized it.
Yeah,
Because
for
for
sure.
most people, if you don't get the subsidy,
Yeah, you don't
it's
get much.
just unaffordable. So it's equivalent to tens of millions of people losing coverage.
Absolutely. And when I try to think politically and neutrally, uh, is that good for the administration? Right. So you wonder, however, because of how people feel about things and not what they're trying to get money for, you just don't know what's going to happen. But
Right, but the
yeah,
impact on healthcare systems
uh,
and other healthcare providers, all of a sudden you have people converted from having reasonable insurance. For those who have never seen an Obamacare policy and seen what it covers and what it doesn't, it's pretty decent insurance. It really is.
yeah,
And if people don't have that, their options to drop down to Medicaid or have nothing are pretty desperate. So it could affect healthcare systems and all providers when they see their revenue streams converted to Affordable Care Act rates to Medicaid or uninsured. Don't you agree?
yeah. Well, I do. It certainly could be a huge impact. And health systems are running, at losses or
Razor thin margins,
they're
yeah.
razor thin margins. And by the way, I think the ongoing mega opportunity for health systems is to really get into operational excellence and the margins that are available from supporting their people in a great way. But
Yeah.
that's my bias. Yeah, but the subsidies going away would certainly be a big shock. Now, again, health systems are not lightweights when it comes to lobbying and building up political pressure and across the country in any kind of district. So the way this has become part of the fabric and providing a base of healthcare to most Americans, I think we don't know which way it's going to go, and I certainly wouldn't be assuming they're going to go away, but I'd be watching it.
Great. Well, thanks. Great discussion, you guys. Good start. Great start. Neil, I'm going to ask you to follow that, and gosh, almost like you and Ken talked beforehand. Boy, he set you up on the deal making thing. What do you think? It's been pretty dry. Anything going on?
Well, yeah. What kind of game is it? Well, right now it looks like it's heading into the championship game with an advantage, but it's some clouds there yet with where the betting's going to be. Trying to figure out on the fly here some analogy, but on the capital markets, and so backing up. So again, Neil Johnson, managing partner, Lawrence Evans and Company, Columbus, Ohio. I'll give the pitch. Fastest growing city in the country right now. A lot of healthcare activity. We have Intel with the biggest chip plant in the world, but also as considered flavor town. We have that fast food that may or may not be good. Wendy's, White Castle, and I like to say we have a now integrated relationship with our neighboring state, Indiana. They've got some hot GLPs then that kind of help offset that. And I think coming into the year, coming out of JP Morgan, first of the year, it was AI and GLPs. And really, if you look at that, that's been two of the hot areas. The stocks have been hot. Investments across the board have been in those areas. While the uncertainty with the election is always a struggle on the transaction side, just that uncertainty, and then you put it Now, post-election with the Trump and the kind of the red wave here, the expectation that there's going to be lower regulation and ultimately positive deal making, the expectation of money moving, deal making happening. We're starting to see the stocks move. It's been fairly frozen the last 2 years. I like to say a Goldilocks thaw, where it's not too hot, not too cold, but we're moving in the right direction. I mean, there's more money than ever before from a private equity standpoint. That money has to move. It has to get invested into the marketplace because they're not in the business of returning capital to investors having not invested it. So they're investments that they placed a couple of years ago that typically their hold period can be 3, 5, 7 years are now dragging out to more 5, 7, or 9 years. And so they're really pushing the limits. They have to come to market. They've not been happy with what potential valuations have been. And so ultimately, I think 2025's the expectation is they're going to be coming to market. Money's going to be moving. And we hope with the concern over the regulation on the high end, some of these concerns of bringing your company to market, there's really been limited IPOs, the public offerings. And so for the larger, and we're in that lower middle market. And so from our standpoint, a lower middle market, kind of the sub 250 million revenue, usually profitable, not startups, entrepreneur businesses anywhere, usually from 5 to 250 million in revenue, software companies that are emerging, community hospitals, senior housing, post-acute, home health, hospice, behavioral health, mental health, which has been very hot, revenue cycle, Tom's group doing a lot there. Still a lot of challenges in revenue cycle, been a hot area. A lot of those outsourcing services as organizations, they can't find the talent, and really that move to outsourcing. Is AI going to save everything? No, but we can't find the people either. And so really moving to outsourcing. Same thing, doing more and more managed IT, cyber compliance. Those have been hot areas. Obviously, this past year with the Change Healthcare, we've been signed up recently with a healthcare cyber compliance focused business. We're seeing the annual assessments, the pen testing, the concern over compliance to get insurance. Happy to talk about that. That's been a rat hole, and that's not going away at the end of the day. And then into transportation logistics. Here in Columbus, we have Cardinal Health. Probably familiar with McKesson, a big presence here. They're really logistics companies. And so more and more tech-enabled supply chain. And then life science, more of the software, regulatory compliance, clinical trials, and different technologies around that's been a hot area, emerging area. We're not so into the med tech or biotech so much, but more provider service software. So as the market's been fairly frozen, the IPOs have been on hold. The market's improving. There's several companies that are expected to come to market, and so to get that money moving, the private equity, as I mentioned, record amount out there. Family offices, the groups that have sold businesses, that money's available, looking for investments, but they've been a little bit on hold and pause. As we're seeing, movement, our phones are ringing, people wanting to know how's the market. Can we, should we go to market? So we're working either, it seems like organizations, physician groups, they're maybe over leveraged from doing a transaction 2 years ago, and maybe a private equity sponsor, over levered the business, and they could be into trouble with the increase, the jump in rates that we saw last year. And so there's some challenges with the markets, and then there's others that have no debt. And so really looking, they don't want to sell. And so maybe doing what we call a debt recap of going out, borrowing some money, taking that money to, repay investors at a moderate leverage standpoint. And so it really seems like there's no in between. You're over levered and kind of in trouble, or you're starting to see some stress there, or no leverage at all, while you await the increase in valuations to hopefully come to market in 25 or 26. So the excitement, the movement's there. However, there is a little bit of concern in different places over the, as was mentioning with Ken, where's the reimbursement going to be in the future? Although several states, they've been increasing in the ancillary areas, whether it's skilled nursing, behavioral, mental health. A lot of the reimbursements, some states we've even seen a bump of 24% Ohio in the behavioral health, seen a lot of, on average, low teens. And so really getting caught up from some of the inflation factors, just back to a profitable standpoint where many of these organizations were struggling and even running in the red. And so will that hold? Will it continue? I don't think anybody expects it to increase, but with just continued labor pressures everywhere, looking at technologies, looking at outsourcing, trying to be efficient themselves, I think that's continued to be the theme here going forward, because there's really no end in sight for the labor shortages, whether it's hospitals or small physician groups across the board. So still a lot of challenges. I think positive expectations going into next year that 25 is better than 24 than 23 from a capital markets perspective. But obviously just some concerns now of what does that mean maybe in the first 100 days? And there's always concern then with the uncertainty, especially where it sounds like there's maybe some big hatchets coming into the government and maybe across the board. And that's conversations recently that we've had with different providers or others around the industry, is just that concern. And even on some academic medical centers, just, from their standpoint, just very concerned how it might trickle down.
Great. Thanks, Neil. Terrific. Ken, Harry, Wade, anything you want to ask Neil or add to it?
Neil, this is Wade, do you think with that extra private equity that's out there, do you think that those firms will become more aggressive with their valuations and purchasing physician groups and healthcare businesses? Is that kind of what you're implying?
As I say, the bid ask spread has been wide. I mean, wider than we've ever seen. I mean, if we go to market with a company, usually you can gauge where it might end up. Now you just don't know. It's all over the place. And so, you know, the sellers, they want a certain valuation. They're still coming off, a little bit of that drunken stupor from 2, 3 years ago of the valuations. And I think they're finally getting the realization we may not get back there. And they, want to get something done. And then the money, they have to put it out there. And so they're coming up. And it's really too based on leverage. And so with the banks mixed, we had some challenges in the banking industry 2 years ago. So coming off of that to I think moving to a more normalized interest rate and still an attractive leverage market. There's what we call private credit out there, and there's a lot of that private credit that the private equity use. Um, the non-bank lenders, happy to get in that discussion. And so I think as the buyers are coming up in price and the sellers' expectations are coming down, and the willingness to transact, that should be moving the needle forward on deals and at healthier numbers, but again, not to where they were 2 years ago. Although, some of the discussions of quality assets, we call them, in the market, they're still getting premiums because there's just still so much money chasing opportunities. And, perfect example, there was a managed IT business that people were surprised it was trading at like 20x forward EBITDA. There was another business as well in the, I mean, med spas, kind of the fringe of healthcare. Again, trading at almost 20x because there's so much money trying to find a platform, trying to find a good quality business in the we'll call the lower middle market, and they're just not out there. Revenue cycle. I think Tom, maybe we were talking. I mean, there's really no companies in the 20 to 100 million in revenue in the market to sell. And there's more companies that I've ever seen in my 25 years doing this, trying to find a company in that size range. And there's some larger companies that came to market, like a Gebs, I may have heard of, that's nearly $1 billion. I think they wanted to get it and transacted about 800 million. There's a couple others that were about a half a billion that transacted, but something that is a platform business that we call it for private equity, that could be a 50 million revenue, diversified, good management team, generating profits. They're just not in market today because they're waiting.
Thanks, Neil. Terrific carry forward. So Harry, welcome as a guest. We appreciate both you and Neil joining us. And so, Harry, you got to play in that. I don't know. I think Walgreens is like $1 billion market or something, maybe.
Oh
You
my
know?
God. Yeah,
Yeah,
much bigger. Yeah.
yeah. So, but you also do fractional work. So you kind of your feet
Yeah.
are been across a lot of camps.
Yeah.
And
Yeah.
in our discussion, I think you had some concerns and some things
Yeah, sure.
for
Thank
where
you
we're
for the
going.
opportunity. So just for the audience, I'm a physician, career physician executive. I'm an internist by training. First part of my career was in the payer side, and then spent a bit of time in the population health, disease management, chronic care management space, Medicare Advantage. Got recruited to be the CMO of Walgreens, as Tom just mentioned. And then I've been a biotech CEO, and now I do fractional chief medical officer work and chief strategy officer work for a number of small companies. So as Tom said, I have really spanned the startup space, the Fortune 50 space, technology, innovation, and diagnostics. The four topics I wanted to comment on, which overlap a little, are science, access, regulation. Maybe we'll do science, regulation, access, and GLP-1s, even though it was briefly mentioned. On the science side, we lost 1 million people in the pandemic, and we now have, and I'm giving my a little bit of political, but we now have some leaders that have been nominated for very important healthcare positions who, frankly, don't believe in science. In fact, they're proud of not believing in science. So, what happens when the next pandemic comes? Are these the people that are going to protect us? And by the way, again, as a citizen, as a clinician, it's not a matter of if it's going to come. It's a when, right? Is it 2 years? Is it 5 years? Is it 10 years? So this scares me a lot because, frankly, what did the pandemic do to the market? What did it do to the health systems and the nursing crisis? So even if you're not coming at it from a pure public health perspective or a political perspective, a pandemic or a healthcare crisis is not good for the healthcare industry or for the stock market. I went to med school with Mehmet Oz. He was 1 year behind me at Penn some time ago. Very bright guy, classically trained guy, very prestigious cardiac surgeon. Some time ago, he still practices, but he got famous and started adopting views that weren't based on science. So that's a concern that I think we all should be paying attention to. It's a black swan event if something god awful happens and the leaders don't know anything about healthcare, in fact, don't trust it. Number two is access. I just want to comment again. I don't believe the health systems can, with efficiency, compensate for 40 million people losing healthcare coverage, even if it's 20 or 30 million converting to Medicaid or uninsured. They're on razor thin margins. Even with all the AI in the world, they've already cut staff. They've already tried a lot of stuff. There's maybe a percent or two there that maybe can be carved up. I don't believe there's any kind of efficiencies in the system that could make up for tens of millions of people not having insurance. Regulation. So regulation, I mean, at the surface, it sounds like it's a good thing for business, but if carried too far, deregulating, it's dangerous for patients and it can be dangerous for business. And Tom and I chatted a little bit before we put together this session, and I was involved with the biggest healthcare regulatory disaster in history. And when I was at Walgreens, we were partnering with Theranos and Elizabeth Holmes. And many of you probably don't know much about the laboratory space, but if you have your own lab, you can have a lab developed test which you develop in your lab, and you basically certify that it works and there's minimal regulation. Well, look what happened there. Theranos rolled out a test that theoretically could, as you know, was built to be able to do a 200 tests with one single drop of blood. And fast forward 4 or 5 years later, and she committed a major fraud. I was involved with unraveling that relationship for Walgreens. We had to invalidate. Let me double down on this. We had to invalidate. We had to tell people that 1 million laboratory tests were not accurate, and they had to go back and recheck them. We had people that were worried about cancer, were worried about all sorts of serious medical conditions because the regulatory apparatus failed. So I'm not saying regulation's good, but when it comes to developing things that diagnose disease and treat disease, you can't afford to get it wrong. These are people's lives. If you're developing an app to make the office a little more efficient or revenue cycle management, regulation may not be the biggest deal. But if it's really around diagnosing and treating disease, it's a big deal. And then finally, so what's the balance is my question. You don't want to have too much regulation, but some guardrails are necessary to protect patients. And then finally, I'm kind of doing rapid, I'm from Philly, so I'm turning on my rapid talk. By the way, the Eagles did pretty well last night for those of you that followed it. Anyway, and I'm a Penn Stater, so Saquon Barkley was rocked it. Anyway, GLP-1s, we talked about it at the beginning. It's a game changer. I mean, we're finding out in science every month that these drugs do something else. Not only do they deal with weight, by the way, overweight is a disease, regardless of what Kennedy says. It's not a lifestyle issue. People who, once they gain weight, just have a very hard time losing it because it is a disease. But anyway, the GLP-1s work for that. They work for diabetes. We're finding they protect your heart. They likely work for heart failure, a weak heart. We're finding they may be a treatment for Parkinson's disease. They may lower the risk of Alzheimer's. They look like they reduce the problems with alcohol abuse and other drug cravings. It's unbelievable. But here's the thing. If they start getting used and covered for even many of those things, they could bankrupt the entire healthcare system. And more employers are starting to cover them. And now Biden's put out there that perhaps Medicare and Medicaid should cover them in more cases than they cover them now. So those could be a real disruptor in how we'll pay for them without insurance going up or the government creating more deficits. I don't know. So just to summarize, I think the losing faith in science is a macro threat. It might seem tantalizing early on, but we will pay a price for that at some point. Access to care, we've made a lot of progress in the US, could really go backward. Regulation, we have to find a balance. We can't just throw the baby out with the bathwater. We have to protect people. And then we've got some miraculous new drugs, not just GLP-1s, but cancer drugs and gene therapy, but some miraculous drugs that change people's lives, but just are fundamentally budget busters. So thanks for letting me rattle on a little bit.
Thank you, Harry, for that. That was great. And for those of you that have specific questions about Harry's fun ride at Walgreens, we'll do that after we stop recording. Okay.
Yeah, it was quite a journey.
There are SEC rules and things that we have to worry about. Okay.
Yeah.
So, Neil, Ken, Wade, what do you think? Any questions for Harry?
I mean, happy to the regulation. I mean, obviously there needs to be some regulation. What's the right balance? That's the magic question. And the business side versus the clinical, and are people doing the right thing. And on the business perspective side, in a lot of cases, it's just been pushing a little too far, and obviously kind of freezing, pausing. I think everybody's in alignment that good regulation or having certain guardrails, but I think there's concern that it's going to be remove everything or start over, and that's very concerning. That the world's going to end, from some discussions I'm having with people right now as we head into 2025. I hope that's not the case, but at least for now, reevaluating many areas and lots of areas. So I think that's the big question that everybody's concerned about. So where do you start? Or I guess the question is, where's the administration potentially going to start with what they're saying is cutting?
I mean, just in response to that, I think we are in agreement there needs to be a balance, but how do you decide where to start or how to go forward when you have people in positions that know nothing? You don't even have the right people to answer the question, even if you formulate the question. That's the concern. I mean, politics aside, Kennedy has no experience in this whatsoever. Mehmet Oz has never run a big organization or a big agency, and the list goes on and on. So who's going to figure out how to go forward?
Next level appointments are going to be really important. Harry,
Right.
what you say about GLP-1s is really interesting.
Yeah.
And we've all lived through decades of, I mean, it's the clinical science that keeps improving and things change around it. Think about the changes in cardiology and all kinds of things. But what I hear you saying is these could be order of magnitude bigger in terms of
Oh
their.
yeah.
So
Oh
if you're anywhere in the delivery system or
yeah.
serving it, how should we be looking 3, 5 years down based on, we've always sort of adapted to the clinical lay of the land and changes based on the science, but if it's going to go faster, how would you be thinking about that if you're running a healthcare enterprise that touches the delivery system?
Yeah. The innovation is just so spectacular with the science where, the GLP-1s are one example, but, after the pandemic started, I think it was a matter of 3 or 4 days that we actually decoded the genome of the virus. Now, it took a long time to prove the vaccine worked, but decoding the genome took, 3 or 4 days. And the CRISPR and the gene editing is taking off. Hemophilia can be cured. I don't have an easy answer, but I think from a health system standpoint, it's the funding. Who's going to make the decisions about who gets these treatments? If you have a fund for the indigent or for people that are uninsured, who makes the decisions of who gets the funding, who doesn't? I think these things are so big that systems are not going to have the funds to subsidize them. Whether pharma or big pharma or biotech steps up and has subsidies, they do, but they're oftentimes hard to achieve. That's a big question. I don't know that there's any preparation for the wave of innovation and how health systems can adapt. I really think that the challenge is more for the payer side of the equation, whether it be the government or the private payer side. I don't think healthcare systems I don't think they can solve it.
Thanks.
Thank you.
But maybe I'm wrong.
No, thank you. But for companies, based on what you said, the GLPs for next year, if you think about what you budgeted,
Yeah,
if you are forced into paying for a lot of the stuff for your
that's right.
employees of any size, or you're self-insured,
Right.
that is something, talking about the purpose of tonight is to relook at your budgets.
Yeah.
If you're going to cover because you think it's right because we're in healthcare, take a look at your budgets, right?
Yeah. It's a game changer. There's no
We
doubt
can
about
talk
it.
more about that I think we'll have time. I think a lot of these things we're going to do. Harry, terrific. Thank you.
Yeah, thank you.
So
Quick
Wade,
question while we're at GLPs. I'm hearing, yeah, we're in the early game with all these developments and, addiction where we're spending a lot of time potentially too. Um, Getting into value-based, some discussion potentially adding it into a value-based plan. Are you seeing anything with that or seeing any success or?
Yeah, yeah. The value-based thing's a whole discussion of itself, isn't it? I mean, the government's saying we're going to be 100% value-based in Medicare and Medicaid by 2030, which is only, 5 years away. But yet most of the healthcare world is still fee for service. But putting that aside, I think putting things like GLP-1s into value-based care models is extremely hard because the benefits that you get out of them are down the road. They're many years down the road, right? So when you start putting in value-based systems, and you say health systems will be accountable for these different metrics. These patients may no longer even be patients in the health systems when you prevent their heart attack 5 years down the road or 10 years down the road. So there's going to have to be some very innovative thinking to figure out how things like GLP-1s or any treatment that has its benefits years down the road, how that would be modeled. But maybe someone on the call or on the panel has a better idea than I do. But I do think it's a challenge.
I could see maybe a addiction where it's maybe more immediate to
Yes,
assist
correct.
that more. But yeah, we would deal with companies in the wellness and kind of the same thing. What's
Yeah,
the ROI there?
yeah,
It can be challenging.
yeah.
right.
But just a quick comment, the ROI to like Medicare is probably higher because Medicare patients, at least on the traditional Medicare side, tend to stay in Medicare for 10 years, 15 years, 20 years. So I think the ROI is probably much better for Medicare.
Let's hold that for a little bit. And actually,
Yeah.
Wade, you may want to get into this as well. So Wade, I asked you to be last because in essence, you are the front door. You are first to our healthcare world. Running a primary care multi-specialty network. in Alaska, doing awesome, great things for the citizens of Alaska. So you're last for here, but I purposely did it because, without you, you're the entrance. Um, and what are you worried about or seeing? And I think you and I talked a little bit also about the value based. So can you weigh in for us?
Yeah, sure. Yep, appreciate it. Really appreciate the comments on the other panelists as well. It's nice to see such a diverse group, especially, geographically as well as just emphasis and experience over the years. So it's really rewarding to be part of this. From my perspective, with the election, one of my one of my bigger concerns, just being a small practice owner, we've got about 70 physicians or so, um, is actually workforce. And so how does if we're talking about mass deportation, um, already a workforce that's depleted, sort of macroeconomically, if you start taking people out of the workforce, theoretically could drive payroll inflation even higher than it is right now. Cut into I'm a family doc, so our margins are slim as they can possibly be in the private sector. How is that going to affect us? I think we're a little insulated in Alaska, but I'm trying to think of it from a global national perspective. And so it very well may affect the independent providers significantly to see if we see a workforce shortage multiply, and then also then see a wage inflation from there. Now that could be offset by a number of things, and so I think the crystal ball is a little bit fuzzy. But the other thing that's interesting, I think, from my perspective, from a provider perspective, is going to be watching the change in the contracting for as they change CPT codes, as I think Ken mentioned. It's going to encourage primary care. I believe that's going to be good for me personally, but I've got members of my group in every specialty. So, how is it going to affect their profitability, and how do we budget for that then in our allocations as a multi-specialty group? Again, not 2025, maybe not even 2026, but need to be thinking ahead just a little bit about how to look for other ways to raise revenue, whether that be through value-based contracting, as you said, or seems like there's going to be an emphasis on Medicare Advantage, which we have zero penetrance in Alaska right now, but that's coming very quickly. So we're delving into that as we speak, trying to bring the first plan to market up here. So that part will be interesting. Overall, I think from a healthcare perspective, the idea of emphasizing primary care is going to be the key. And I believe also nutrition is going to be the key as well, because all these GLP-1 issues are coming from lifestyle problems. I mean, obesity is a condition, but it is definitely lifestyle moderated, mitigated. And so I've been prescribing GLP-1s for over 20 years for my diabetics and using them for weight loss. But overall, my success rate in keeping patients within their normal range of weight has been low with those medications, because as soon as they go off of them, they're rebounding up. And so we need to really emphasize from a Medicaid perspective in my state, we need to emphasize, the type of food that our beneficiaries are eating, the amount of exercise that they're getting, those sorts of things is going to be far more important, I think, from our workforce and from our state's population's health than the access to the GLP-1s, for instance. So they're a great tool, but I don't think they're going to be the answer to all of our prayers, keeping our country healthy. And then lastly, I'm curious about with margins being so thin, I've noticed in the last couple of years that our capability of going to the bank and getting financing when we need it has substantially uh, stalled, as Neil was saying. And I'm excited actually maybe about a little bit of deregulation, a little bit of freeing up of the banking sector in order to allow us some capital to grow and assure that our survival is there if we do hit a tough time. So I'm real happy to hear that you think that there's money coming and money out there. And I think as interest rates drop and as regulation goes down, I think our banks would be more willing to lend us money. So from that perspective, that's an interesting concept that we can sort of put in our quiver when we're looking at doing our budgeting and business planning for 25, 26. I understand nothing's probably going to happen this next year really meaningfully, but 26 for sure. So
Great. Thanks,
Well,
Wade.
Wade, maybe we
Terrific.
should talk. There's, I think, capital out there. May not be with your local bank, and you may not like the rates, but there's capital available.
yeah, and that's the key is probably not the locality necessarily, but what the rates are going to be and how willing they are to lend against what as we grow and expand. So yeah, I appreciate that.
No, terrific. So, you guys, from Wade's perspective, provider, we know that all of us, I don't think it's actually official published yet for a couple more weeks, but the proposed rates for physicians is down 2.5%, correct? And obviously we talk about with the new administration, we'll have to see after 100 days. Is that something that may get stopped in the first 100 days? Do you guys think in what you've seen before? Ken, what have you like
Yeah, I would
the
not. I mean,
provider side?
I would not hazard a guess, yes or no. I mean, yes, it could certainly be stopped and rolled back and end up with something else, certainly based on past practice. But I don't have a crystal ball on that one.
Okay. Okay. What else for the people that are at the front end of this, you guys? What should they be looking for in this new administration? These are providers that we got a shortage of docs. You guys
Yeah.
all know all the problems. They don't have any money because there's no margins for investment. All those kind of areas, other than outside money. Um, is there something we should be pushing toward? Is 2025, in essence, is 2025 a stale year because it's the transition year? Do you think for our providers?
I guess define stale. Yeah.
Basically, like, yeah, where other
I don't,
professions may do
I don't think
really
there's a
well
shortage
next
of
year.
patients. I think it's, can you service them, to the quality that everybody's happy with and get paid for that?
Yeah, that's the
I mean,
yeah,
my instinct on that question is that it's stale from a regulatory standpoint for the first part of the year. Second part, they signal what they're going to do. All of a sudden, health systems are going to be focused, panicked, or pleased or whatever, and providers, depending on where you sit. On the private side, and the way that the private markets, they can move and have an impact a lot faster. So I think we just have to see early days what happens on that side, and then it's that so I think the things move slightly different speeds based
right,
on signals and appointments.
right, terrific. So we're almost to our 50 minutes. So to all the Medvallistas and everyone that is on, here's how we're going to do this. For the next 10 minutes, if you'd like to put in the chat a question, we'll try and get to them. We're going to turn off the recorder now.